All right. Can everybody hear me now? There we go. Good afternoon and welcome. I'm Liz Sacco, a co-chair of the Women's Leadership Council's Education Committee. Thank you all for being here for the third lecture of our 2018-2019 series. I would like to thank Northbridge Insurance Agency and Carol Wilson for their sponsorship for our lecture series. A bit of housekeeping. We ask that you would please take a moment to silence your phones and pagers at this time. As you may know, the Women's Leadership Council has embarked on a very ambitious fundraising initiative. We are working every day to raise $2 million to endow the Women's Leadership Council Hospice Comfort Care Fund by the end of 2019. This endowment will generate funds that can be used by our palliative care and social work teams to help patients at the end of life. Modest grants from the fund will help families in need afford supplemental nursing and hospice care in a variety of settings, including home, hospice, and long-term care facilities. We are excited that our fundraising efforts, including the $120,000 we raised at last year's Ladies' Night Out, are off to a great start. And the tickets for our 2019 Ladies' Night Out are now on sale. It's a fantastic night of fun, and all proceeds benefit the Comfort Care Fund. You can visit our website for more information, giving.laheyhealth.org/LNO. We invite you to Ladies' Night Out on May 2nd and consider making a gift to the Comfort Care Fund by using the envelope you will find in your lunch bag. Gifts of any amount will help us really make a difference. One of the primary goals of the Women's Leadership Council is to help educate and empower women to be their own healthcare advocates. It is gratifying to look out and see so many women and a few very welcome men here in the auditorium. Our hope is that you will find the presentation to be educational, informative, and applicable in your lives. Today, we are thrilled to welcome two expert physicians from Lahey Hospital and Medical Center. Dr. Hunter from the Department of Orthopaedic Surgery and Dr. Toraldo from the Department of Endocrinology. Dr. Hunter has 31 years experience in orthopedic surgery, specializing in complex upper extremity issues that include bone fracture. Dr. Toraldo is a bone specialist, focusing on bone diseases including osteoporosis, and we're going to have to help me with this one, hyperparathyroidism. Please help me welcome Dr. Alice Hunter.
Thank you very much. I am going to be Dr. Toraldo's promoter today. I don't know that I'm going to say a lot educational, but I will encourage you why you need to see either your general practitioner or Dr. Toraldo regarding your bone health. Many of you in the audience, we work together and we see patients on a regular basis, and we try to encourage them in the direction of bone health, and it doesn't always work, and I'm going to try to point out the importance of why it needs to work. So first of all, thank you, Dr. Toraldo, for giving the important information for today. And I also want to thank Dr. Andrew Marcantonio and Casey Bramlett, PAC, who are two people in our department that keep pushing the importance of bone health. You know, we get so into looking at a fracture, and we forget really what it means down the road if we don't address that. So, simply, bone health, we're talking about bone quality and bone mass. It doesn't take much to look at these two pictures and notice the one on the right has a lot higher risk of fracture than the one on the left. When we hear the words osteopenia and osteoporosis, what we're really talking about is a metabolic bone disease, and Dr. Toraldo will go over that more. Part of the slide got cut off, which leads to decreased bone mass or poor bone quality. And you can see there's normal bone, and then as you transition to the right, it's less dense. To to the lower left, less dense. Then you have severe osteopenia, which was that fragile piece of bone which you saw on that first slide. Why worry? You know, people walk in my office and they have this simple little finger fracture like you see up here on the left, and next thing you know, they come in with a wrist fracture. There's a spectrum of fractures, and it can be the simplest fracture that then can become something catastrophic for your life. A fragility fracture is defined as a fracture that results from a fall from a standing height or less. So if you fall from a height or less and you fracture something, it probably is speaking to your bone density. So it's something to keep in mind. Osteoporosis is the major contributing cause to those fractures. It accounts for over 2 million fractures a year in the United States. And here's a point that is important. All broken bones don't become perfect again. All right? And I'll say this again. 75% of those suffering a fracture do not return to their pre-injury state. It can be as simple as that finger fracture where you lose motion, or your wrist fracture, or your shoulder fracture where you're never coming above this level, or it can become much more catastrophic. So why worry? Important number. Patients sustaining a fragility fracture, a fall from a standing height. I just walked and I tripped and I fell and I break my wrist, are 5 times more likely to sustain a second fracture. So someone walks in my office and they have a wrist fracture. They are 5 times more likely to get another fracture, which can be this hip fracture, which then lands you in this bed, which will forever change your life. So how does the conversation go in my office? When I first meet a patient, I ask them about obtaining a bone health evaluation. And someone said, like, my primary care is taking care of that, and most of them do a great job, so that's never a problem. And others say, I agree, let's look into it. There's a whole subset of people that say, have you read the label and the risks on those potential medications? And then I say, what you just heard, patients sustaining a fragility fracture have 5 times more likely to sustain a second fracture, and 75% of those people will not return to their pre-injury state. You might, and not unlikely, wind up in a hospital bed. So what can we do? From the orthopedic surgery point of view, for all our caregivers in our department, we can't just pay attention to the fracture. It's real, you know, I've seen you as patients sometimes. You walk in my office and I get all focused on your hand or your shoulder or your wrist. We got to look at the whole person, because that's what's going to change your life forever. And we need coordinated care, as I mentioned. Most primary cares are all over this, and they're addressing this. But for those that are not, we need a referral to our endocrinology service for bone health management. So from the orthopedic point of view, please remember to think of our patients as a whole person, not just a fractured bone. And when we are with a patient, be open-minded towards the subtle fracture can forever change your life. And just be open-minded as us as providers, and when we're the patient, because many of us are going to be on that same side. In fact, I'm heading in that direction. We need to be open-minded to treatment. Now I'll let the important guy come up and tell us what that's all about.
Okay, give me 1 second. Okay, my name is Gianluca Toraldo. Thank you, Dr. Hunter, for the introduction, and thank you to the organizer of this fantastic meeting, I have to say. And thank you all of you to be here. So I feel that Dr. Hunter already was able to tell you why this meeting is important. This meeting is important because a fracture is an event that if we can, we don't have to have. But it's something that can be related of a lot of problems. And my duty here today is to show you, and at least to convince, and I hope to convince you, that we can do something to make our bones strong in order to have a very good and healthy and independent life. And I'm going to try to do this talking about what osteoporosis is, why bone health is important, how we can diagnose osteoporosis, and what we can do if we have osteoporosis. Now, this one is the definition that you can find in a medical book, or if you ask Dr. Google, about osteoporosis. In this definition, there are, I believe, two important concepts. One is the concept of bone strength. We will discuss about this a little bit later, but what does it mean is that you are not a number on a machine. The number that the bone density gives you is not what really determines your risk of fracture. The second one is really the most important thing, the fracture. What does it mean? Is that osteoporosis, it is not a disease. Osteoporosis is a risk factor that can lead to a disease that is the fracture. That is what we need to understand when we talk about osteoporosis. Again, not an abstract number, but a fracture. This is why, since the time that I started to focus on osteoporosis as my main professional love, I always believed that the real definition of osteoporosis is this one, or this one. Is the expression of the face of these people that I don't want to see in my patients. We are all very aware of important issues in medicine like heart attacks, strokes, cancers. And we have no problems when someone, a doctor or a medical provider, tells you that you need to take a chemical to avoid these problems. Even if you never had this problem before, even if you don't have even family history of this problem. What I can tell you is that these are very important problems. But if you look at the incidence of fractures, that is much higher than those problems. That means that the chances that in your lifetime to have a fracture is higher of having a stroke, a heart attack, or even cancer. And actually, 1 in 2 women, or 1 in 5 men over the age of 50, they have the possibility of, the chances to break a bone in their lifetime. And a fracture, again, is a very important event. It's a very important event because it has a huge impact on our healthcare system. After a fracture, a fracture means hospitalization. Visit to the ER, means doctor visits, means unfortunately, going nursing homes. But what I care the most, I have to tell you the truth, is not the burden of the healthcare system. It's the personal impact that a fracture can have. Like you already heard from Dr. Hunter, a fracture again is an event that you don't want to have. Because a fracture has consequences. 1 in 3 people that have a fracture, they complain of chronic pain. 80% of people that they have a hip fracture, they don't go back to their original state. And unfortunately, we need to talk about this. Fractures, especially hip fractures, can be linked to higher mortality. Despite this, 70% of people over 65 years old have never been screened for osteoporosis. And what is, I believe, more scary for me is that 1 in 5 women who broke a bone had to have other 3 fractures before they are diagnosed with bone fragility. So how can we know if we are at risk? These are main factors for bone fragility. Some of them, unfortunately, we cannot change. Other ones, maybe we can. Gender. Being female already exposes you to 80% more risk of having fracture than men. And I will explain to you a little bit later why. Having family history of a fracture exposes you to a 65% more risk to have bone fragility. Age is an independent risk of factor. That means then we go farther with our age. I say when we grow wiser, our bones are not the same than before. Our bones are more brittle. So that bone density value of 65 years old, the same one, in an 85 years old has a weight much higher than the 65 years old. Having a prior fracture, especially if it's a fragility fracture, we are not talking about, falling from ladders or like roofs or like car accident, has a higher risk of future fracture, something that we call domino effect. And even medical condition or medications can be linked to worsening bone health. When we talk about medical issues, I believe that this goes back to the concept that Dr. Hunter was saying, that we are not only a bone, or only a thyroid, or only an adrenal gland, or whatever, and heart. We are a body. That means that everything is connected together. When something is wrong in one place, some other things are wrong too. This is why, medical conditions like diabetes, or problem with the thyroid, or a problem with the joints, especially rheumatoid arthritis, can affect the bones. And even medications. Even common medication that most of you most likely they are taking. Like, for example, antiacid, especially medication like omeprazole, what we call PPIs. But even important medication like, for example, steroids. Or important medication like medication that we take when we have, for example, breast cancer, like aromatase inhibitor. Or medication that we take because, for example, we have low testosterone and we need to replace it. Or medication like, for medication for seizures. So there are a lot of reasons why our bone health can be impaired. And I think it's our duty, if your doctor doesn't ask you to do a screening test, to actually ask for it. Like we ask to do a lipid panel. I'm pretty sure that a lot of people, like you say, hey doc, why can't you check the cholesterol? Or like sugar. And if you need to do a screening test, your doctor is going to order the gold standard for the diagnosis of osteoporosis. That is the bone density. How many of you had a bone density before? Okay, good. Yeah. So bone density is a pretty easy test to do, relatively quick. Uses X-rays, but the amount of X-rays that is used is very minimal, and can actually give us some important information. Usually, the people that they get this test are people that are 65 years older, or theoretically, men that are 70 years and older. Now, I can tell you that not a lot of men are screened for osteoporosis, and this is a blame that I have, and I hope that is going to change. But even if it's younger than 65, or you have risk factors, needs to be screened for osteoporosis. And I believe, personally, that everyone after menopause should have a bone density. That is a baseline, like we do baseline for other things. They are important to understand if the loss of calcium happens after the menopause, because sometimes it can be even before. And why don't know something when you are 55 instead of 65? Now, what bone density does is checking the amount of calcium inside, theoretically, your bones. And the number that is given to you, that is called T-score, is the correlation of that number against the best bone density in your lifetime. They usually is the one of a female, if it's a female or a male, of 30 years old. I'm gonna see why 30 years old, but believe me, that is the moment in which the bone strength is the best one in your lifetime. And accordingly of how far is your number to that standard, we construct some kind of ranges. They make us say to you, you have normal bone density, you have osteopenia, or you have osteoporosis. And what does it mean is that the more you go towards osteoporosis, the more your risk of having a fracture increases. Usually, bone density is always thought to be the best surrogate for bone strength. And that is wrong. What we learned is that bone density by itself cannot tell us what is your risk of fracture. In fact, technically, bone density can explain 70% of the bone strength. Pretty good number, but not 100%. And unfortunately, we don't have anything that can make us measure bone quality. Bone strength. Because bone strength is a combination of two factors. One is bone quantity, that is what is measured by bone density, and the other one is bone quality. Very abstract term, but that is the example that I was doing when I was practicing overseas. You have two buildings. Where I come from, buildings usually are made of bricks and cement, okay? So what I say is that you have two buildings, both of them are constructed with the same amount of materials. One is thin and very tall. The other one is flat and long. If there is an earthquake, that unfortunately is something common where I'm coming from, which one of the two buildings goes down? The amount of material is the same, the structure is different. That is why, if you plot fractures and bone density, you will see that the majority of the people that have a fracture, they actually are in osteopenia range. The reasons are two. One, because again, there is something else called bone quality. The other one is because there are more people with osteopenia. So technically, the chances to fracture is higher. So, if bone density is not the only thing that we need to take care of, and we don't have anything that can really make us understand what bone quality is, how can we determine the risk of fracture? Now, usually if someone is, not an expert but likes this and, reads about it, you can kind of, in your mind, getting risk factors, that some of them we already discussed about it, put them all together and try to give a personalized risk of fracture. Because this is done easily only, if you have if you do this almost every day, what was done was to actually build a calculator that takes important risk factors, put them all together, and tries to give us a 10-year risk of 1, fractures in general, 2, hip fractures. This is a very important tool that everyone can use, and this is used especially by primary care doctor, that can make us understand if you need to be treated or not. Now, that is something that can only guide you, okay? Nothing, and I believe, and I hope, never is going to happen, that a machine is going to make a job of a doctor. But this can be technically helpful, and can be used especially if you are in a range of osteopenia. But again, you have other risk factors. If you have osteoporosis, theoretically you should be treated. And again, briefly, the numbers that we look for is this. If you have a risk of having any osteoporotic fracture more or equal to 20%, or if you have a 10-year risk of having a hip fracture more or equal to 3%, theoretically, you should be treated. Now, in 2019, there is now another way, technically, of screening for osteoporosis. And for what I know, that is something that we have here at Lahey only. I don't believe that anyone in Massachusetts, and most likely in New England, has this. What it is a machine that uses ultrasound to get some characteristics of the bones, in particular the tibia, so the shin bone, and tell us the risk, the possibility of having osteoporosis. So what this thing is a point of care for osteoporosis, like we do with a finger stick, for example, for sugar, or like, other ways to do, like, cholesterol, or like, a blood pressure cuff to see if you have hypertension or not. So what happens is that we can screen with this machine a lot of people very easily. Again, ultrasound, portable device, inexpensive, but can give us a huge amount of information because we can select the one that they need further evaluation with the bone density, for example. We have this machine today on the back. So if at the end someone wants to see what really is, feel free to go. Deborah Sullivan is our bone nurse, is the expert in this machine, and she's going to definitely be able to explain more than me, better than me, what we can do. Now, we understand what osteoporosis is. That is, again, the risk of having a fracture. We understand what are the risk factors. We understand how we can diagnose osteoporosis. Now, we need to see what we can do. And that is the part of my visit that is the most fun. The reason why, because all of you has no problem in taking medications for, again, blood pressure, high cholesterol, diabetes, pain. And I have no idea if I'm the only one that talks about side effects of medication, but, you take this, you trust the doctor, no problem. When I have to say something, I don't know if it's the accent, but everyone, even if I say to take calcium, tells me what they heard. Now, I don't want to say that these things are wrong. What I want to say is that everything in life has the other side of the coin. There is nothing that is only good. There is always, again, a side effect. Eating strawberries can have a side effect if you eat too much or if you're allergic. So it's always a matter of balance. And what I'm trying to do usually is help you. So again, I'm going to try to talk about something that I know the pros are more than the cons. But I need your input too, because it's something that we need to do together, because at the end of the day, you are the one that has to take something. That is why I have no problem in, discussing about this. And if you understand pros and cons of your choice, I'm going to support you. I'm not going to say, okay, you don't want to do what you want, you're on your own. We're going to continue to follow you, because it's possible you're going to change your mind later on. So it would be not very intelligent in say, okay, don't see me anymore because you don't want to take any medication. Especially because when we talk about osteoporosis, like in other medical conditions, there are only two sides. There is the non-pharmacological side, and there is the pharmacological side. Now, when we talk about non-pharmacological side, there are two important things. One is the calcium, and the one is the vitamin D. Now, I'm assuming that everyone understands why calcium is important. Calcium is, is the basic unit to build the bone. I don't know if a lot of people know what vitamin D is, first, and what does it mean, why it's important. Vitamin D is not a vitamin. but it's a hormone. It's not a vitamin because vitamins are, I don't know what, substance, something that we cannot produce. And we need to take it from outside. Vitamin A, C, E. Vitamin D, we produce it. And because I believe that the body is a perfect machine, if we produce it, it's important. And what vitamin D does is a lot of things. But the one that for sure we know helps with absorbing calcium from the gut. What does it mean is that even if you take a lot of calcium, but you don't have vitamin D, you don't take it inside you. So it's like if you don't have it. And calcium is a very important element in our body. It's important for a lot of things. And in fact, the body has a very intricate and fine mechanism to maintain level of calcium always normal. This is why a calcium level in your blood, even if it's normal, doesn't tell anything about the real deposit of calcium. Because that number needs to be always normal, even if the body auto-destructs itself. Because if you don't take it from the diet, the body is taking it from the bones. That is why calcium is important. This is why vitamin D is important. How much? What I say is usually between 1,000 and 1,500 milligrams of calcium a day. And if you stay on these numbers, believe me, all the bad effects that you read about kidney stones and about atherosclerosis, or clogging of the arteries, it shouldn't happen. Vitamin D, usually, personally, between 1,000 and 2,000. But again, it can be different. We can go even up to, 7,000, 10,000 a day, believe me. Now, when we talk about calcium, everyone thinks about dairy. And because I am someone that believes the calcium with the diet is much better than calcium with supplements, in my visit we discuss a little bit about how to take calcium with the foods. How to take the right amount of calcium in the food, even if you cannot drink milk because you don't like it or you have intolerance. Because calcium can be present in a lot of things. And believe me, it is not difficult to reach 1,200 to 1,500 milligrams of calcium a day only with foods. I'm not going to bother you why I believe the calcium with food is better than calcium with supplement. We can talk about in the question, the another section of the questions or offline. But believe me, it is not so difficult. And how you can understand how much calcium there is in products? Technically, there is an easy trick. You look at the percentage of calcium and you add a 0. Okay? So I hope that this can be helpful. Vitamin D. Vitamin D is something instead that is kind of tough to take through foods. So that is why supplementation, I believe it's a good and easy thing to do. And again, in this case, I'm okay with taking a capsule. But again, it's a supplement. It's not a medication because it's the same exact vitamin that you produced. And after that, there are important things. Like in other medical conditions, consume a balanced diet, perform exercise, but not form of exercise in bone health are created equal. The form of exercise that we like is what we define weight-bearing exercise. Walking, jumping, dancing. Exercise like swimming, cycling. Great exercise, you need to do it if you like them, but again, they are not the best friends for your, of your bones. Because they happen in absence of gravity, and if the bones, they are not stimulated even only by your own weight, they become lazy. That is what happens to the astronauts when they go to the space. Their bones lose a lot of calcium. This is one of the reasons why we cannot go to Mars. I'm not kidding. You're going to get disintegrated. Believe me. And after that, other important things, again, avoiding tobacco, limiting alcohol, really, really important factors, especially alcohol, because again, the most important therapy for osteoporosis is do not fall. That is the most important thing, avoiding traumas. You know, it's much easier to say than do, but remember, every fall happens for a stupid reason. So we need to try to minimize the stupid reasons. And after, there is the tough part, the medications. I don't like medications, but at the same time, if they work, I think that we should consider them. And medication for osteoporosis work. And I feel blessed that I'm taking care of a condition that has a therapy. And I feel sad when you have a condition that can give you a problem, that has a therapy, and someone tells me that doesn't want to do it. But I accept it. I learned it. I'm doing this since 1999. I totally understand. This is why I'm willing to follow you, and if you change your mind, I'm here. Now, before talking about medication, I want to I hope to let you understand how this medication work. Because one thing that I want the people that I meet in clinic to understand is how something works. Because you can, like this, when you can decide, but you can do the most educated decision possible if you really understand the pros, cons, and how something works. Because taking passively things the doctor tells you to do, I don't think is the right thing to do. Because if you don't believe in something, you're not going to do it. Bones are alive tissues. Bone is an alive tissue. What does it mean? Is that bone changes throughout your life. From the time that you are born until the age of 30, bones grows. The amount of calcium in the bones increases. Between 30 and 45, remains stable. And after that, starts to decline. The yellow line are women. The red line are men. This is, I believe, can explain why women are more prone to have osteoporosis than men. Rookie mistake. There you go. Like I told you, bone density grows until 30 years old. Remember that 30 years old? Peak of bone mass. Maximum amount of calcium that the bone can hold. And like you can see, the peak of bone mass in a man is higher than in a female, in a woman. After that, there is another moment of the life, menopause. And that is when a woman can lose a lot of calcium. Men, they lose it too, but you can see the difference of how fast he's here, boom, and now he's here. Now, that changes happen because in the cells there are cells, and the most important one are two. One is called osteoclast, and the other one is called osteoblast. Osteoclast is a cell that removes all bone, damaged bone, from your bones. Osteoblast is a cell that forms new bone. And this is very important because this cycle of chewing up and forming, called bone remodeling, is important because every 7 to 10 years our bone renews itself. So what does it mean? Both cells are very important. The problem is this, that going forward with our age, menopause, other factors that we discussed before, they make work the cells that they eat the bone, they start working more than the cell that they form the bones. What does it mean is that you go into negative balance. You lose more than you gain. This is why one set of medication that we have to take care of osteoporosis are medication that they try to reduce the function of the cell that they eat the bones. These are the majority of the medication that most likely you heard. The reason why is because are the first medication that they entered in the market as real medication for osteoporosis. And the second one is because, again, maybe because linked to that, but because doctors, especially primary care doctors, they feel more comfortable in giving this instead of other medication, a little bit more new than this one, but good, at least I can say in the same way, or maybe even better. There are medication that they act on the cells that they form the bones. So one medication, part of medication, okay, they reduce the amount of bone that is destroyed. The other one pushes more bone to be formed. These are all the medication that, classically we use for osteoporosis. And again, the one that usually the doctors they talk about are this one. This one is the one that everyone heard and everyone is scared about. Fosamax. No, okay. Yeah, okay. Strange. Usually, I have like a reaction. Okay. How many of you heard about Fosamax? How many of you took Fosamax? How many of you they were told to take Fosamax and you did it? Okay, I'm pretty sure more, but if so, this everything except okay, let's put it away. Medication that they go. So these medication are very good in reduction of risk of fracture. I cannot tell you which one is better because I don't have a study that puts them all together, but I can tell you that these are medications that really changed the osteoporosis field. And yes, they have side effects. But again, side effects they're always present. Coming to this meeting has side effects. Right? You have to pay the parking. I don't know if you pay parking, but So everything in life is pros and cons. So you need to kind of, understand the risks and go on whatever you think is the right things for you. And when we talk about side effects, again, I'm not gonna, we can discuss and, if you have questions about it, but the one that scare the people the most are the long-term side effects that can be seen in people that take this medication for more than 7 to 10 years. That they can, but doesn't mean that it's gonna happen. And one of it is the fact that there is this thing called osteonecrosis of the jaw. How many of you heard about that? Again, this one, like another thing that they say, that this medication taken for a long time can increase the risk of fracture. If you put on a scale pros and cons, you have, from one side, the fact that the risk of having a major fracture without this medication is almost 1 in 4, 28%. The risk of having these side effects, the same risk that you became struck by a lightning. Again, someone is going to get struck, so it's up to you to understand if that is higher than, again, the protection. But after, I want to spend a few minutes, unfortunately a few minutes, they gave me the 5 minutes warning, about this medication. These are medications that I believe they should be used first on everyone that has bone fragility. The reason why these are medications that, like I told you, they build bones. What does it mean? They can make you go from here to here. Some of them in less than 2 years. What does it mean? Is that I define this medication time machines for the bones. You're going to go back in time, so you're going to rebuild, and after that, because this medication can be given only for 2 years, again, I'm not going to tell you right now why, but we can discuss. We can use the other one to kind of maintain, because the other one are great medication. This one are great medication. Again, I cannot tell you that one is better than the other one, but I believe, from a concept standpoint, it's better to rebuild and maintain instead of trying to maintain, and only if the maintenance is not good, you try to rebuild. Especially because we saw that if we use this medication before the other one, when the bone is naive, so never saw any medication for osteoporosis, the effect is higher. Again, I would like to talk to you longer, but I can't, so important thing to remember. Get calcium and vitamin D daily. I believe food is better than supplement, but, it depends. Supplement is okay too. Weight-bearing exercise. Know your risk factor for bone fragility, and ask, if the doctor doesn't do it, to get a diagnosis. And medications are not enemies. Thank you so much. Sorry? Yeah, absolutely.
Hello? Okay. So we're going to open it up to some questions and answers.
I'm on anastrozole for 5 years, and I noticed being much more achy, but I wouldn't want to give that up. I know, could you suggest some alternatives to counterbalance the aches?
Yeah, you say anastrozole? Okay, so anastrozole, it is not a medication for osteoporosis. Anastrozole is a medication that usually is taken by someone that has, unfortunately, breast cancer, and is a medication that is able to eliminate all the production of estrogen from your body. Very important medication that you need to do for 5 years or even longer, but as a side effect, the side effect is loss of calcium. This is why we collaborate with a colleague of oncology, especially with Dr. Sager. And what we try to do is, because this is a medication very important for you, and because it's a medication that most likely is going to induce bone loss, that adds up to the age, the menopause, other things, we try to take care of that in order for you to continue to take a very important medication, reducing the side effects. One important concept: osteoporosis doesn't hurt. This is why osteoporosis is not a disease. Osteoporosis doesn't have any signs and any symptoms. This is why, for me, osteoporosis is a risk factor, like cholesterol, risk factor for heart attack and stroke. You don't feel it, but can hurt you. So the aches, I believe, are most likely the medication per se. What I can do, if doing something for your bones that maybe are losing calcium in order to, kind of help, you to continue. But I cannot tell you that if you start medication for osteoporosis, the aching pains are going to go away. Osteoporosis can hurt in only one situation: fracture. Okay? So you don't want to have pain from osteoporosis, believe me.
Thank you, Doctor. Every night at 6 o'clock, I'm told to, via the television, to take Prolia.
Yeah.
How can they do that when they...
How you can, sorry?
Prolia.
Yeah. So Prolia, or there is commercial name, there is only one, so we can call it with a commercial name, but it technically is denosumab, is a newer medication, but again, we know it now for like 10 years, okay, so relatively new. And it's a medication that is part of that group of the medication that they block the cells that they eat the bones, okay? And it's a medication that is to be given every 6 months. And what differ this medication from the other one, the Fosamax or the other one that is called Reclast, is that Prolia stays in you only for 6 months. What does it mean? Is that if after 6 months you don't take the medication, you don't have the medication anymore in you, and you lose all the effect. Not something weird, is what happens if you stop your blood pressure medication, right? So, but again, stays in you only for 6 months. So, it's a medication that is another weapon that we have in the fight. It's a medication that is preferentially given to people that have a kidney function that is not perfect, and is an option. Again, I cannot tell you that this is better than Fosamax, than Actonel, than Reclast, than medication osteoanabolics like Tymlos or Forteo, because I don't have any study that put them all together. So it's another option, and if people likes to have an injection, like a flu shot every 6 months, done in our clinic, in this case endocrinology, and that is what believe can help, is great. For me, every medication of osteoporosis is great. It's only a matter of finding the right for you. The one that allows you to take it as much you can with less anxiety possible. I want to help you. So if I talk about medication and I see someone that becomes anxious, I told them, don't do it. Because I want to help you, not give you another problems. Right? So it's okay. Do what you feel right now. We are going to continue following you. And if we see that things are not going the right direction, we will act. And you're going to be more open again to get the risks now. At the same time, you need to understand that don't doing something for a longer time can expose you to fractures. But I don't have a magic ball. I cannot tell you if you don't do this, you're going to fracture. This is why, when you come to me, it's an open discussion. I'm going to give you homework to do. I'm going to give you all this medication to read about it. I'll give you all the time that you want to talk to your family, your doctors, again, Dr. Google, whatever you want. And after that, you come back and we decide what to do.
Thank you, Doctor. Is the tibial scan similar to the heel scan that used to be done years ago? And if so, when is there an indication to follow up with a DEXA scan?
Yeah, so that is a good question. So the question is about this device that we have with to screen for osteoporosis. So it is true. This is not the only device that was invented to screen for bone density. There was another one that is the heel device. In Europe, we had another device that checks the bones of the hand. This is kind of a device that seems much better than the other one. It's a device that I believe everyone after menopause should be screened with. And again, accordingly to the risk level that this device is going to tell us, that can guide if you need to do a bone density or not. So the indication right now are kind of the same on the bone density, but I believe that this is a device that can be used because we can screen a lot of other people. We can go to, again, when you go to a health fair now, you can be screened for osteoporosis too, and believe me, bringing a DEXA machine is not easy, like bringing like a little probe attached to a computer. And it's something that, again, I felt there was a very important plus to have here, and I'm very happy that Lahey gave us the possibility to have it. And like I told you, we have it in the back. Deborah is there, and feel free to kind of go and check it out. And for what we know, it's there is a very good concordance to what the machine tells us and the bone density. I am someone that believes to things only after that sees them. So we are doing actually an internal study to see if there is this concordance before going live and say, hey, we have this, we are the only one, we are the best. We are not, but
Okay, to respect everybody's time, we're going to just take one last question.
Thank you, Doctor. I'm just wondering what is the span of time between bone densities tests?
Yeah, so that is a great question. So I believe that the best timing is 18 months. Because we can't, usually 2 years is fine. So 1 year maybe is a little bit too, not a lot of time. 2 years, that is what, especially Medicare wants. I'm okay with it. But again, if this machine that we have works, this doesn't mean that we cannot, for example, follow you with another thing. Plus, when I follow people for osteoporosis, I don't follow only bone density. We have the ability now, through the blood, to check some lab works that indicates how much the little cells that eat the bones work, and how much the little cells that form the bones work. And that is very important, especially when you take medication that they reduce the function of the cell that they eat the bones. Because remember, another problem with that medications is that if you take the medication for a long time, they told you that this medication can actually break your bones. The reason why is because their little cells are very important. If you block them too much, so if the medication works too much, you actually can hurt the person that takes it. This is why I usually follow this marker in order to evaluate when to stop, when to start, other things. So the bone density, the 2 years is fine, but this doesn't mean that yearly you cannot get other things in order to see if your vitamin D is good, if your calcium level is good, if your marker are okay. So, but the 2 years I think that is okay.
Thank you.
Absolutely, thank you.
Thank you. Okay, so thank you again to both Dr. Hunter and Dr. Toraldo. And thank you again to our sponsor, Northbridge Insurance Agency. I hope that you've all enjoyed the presentation. Our lecture series will pick up again in September. Please keep an eye out in August for a full listing of topics for our 2019-2020 lectures. If you would like to learn more about the Women's Leadership Council or join our mailing list, please feel free to talk with any of our members. We are all wearing name tags today, so we should be easy to spot. We always welcome your support and would love to talk up our Ladies' Night Out event as well. Thank you all again for coming and have a terrific afternoon.